We'll explore the synergies and differentiators of ACO REACH and MSSP, revealing the subtle nuances that set it apart. Buckle up as we hack into the benchmarks and navigate the labyrinth of risk adjustment strategies, all while exploring the red pill or blue pill decision for your organization. Is ACO REACH the chosen path?
Welcome today. We are talking to Dr. Decker about an important topic, which is of ACO REACH and how it is similar and different from other ACO models such as MSSP and direct contracting entities. So welcome, Dr. Decker.
Thank you for having me. Excited to see you and talk about this really important topic today.
Great. So my first question to you is that DCE was rebranded as ACO REACH, and there was a lot of political pressure on Biden government to discontinue the DCE model. And they actually ended up rebranding it in 2022. Who do you think won that battle and who lost in this rebranding?
I think that the intention, without declaring a winner or a loser, but the intention really was to continue to evolve and make it better for patients. And so again, they weren't seeing the results that they anticipated. And one of the key changes between the old model and the new is that you need to have at least 75% of your board representation be practicing physicians. And so I really see REACH as that, that throwing the mic, if you will, or throwing the gauntlet to say that, that physicians do this work and do it well. And so we need to organize programs and get them into total cost of care, shared savings arrangements, taking risk to be able to do this work, remain independent, and that there's value in that. And so, how can we empower our physicians to do this important work?
Great. However, I did hear that you can go for an exemption from that 75% participation for providers. And I think some of the associated parties were not so happy about that. Another important difference is SDOH. What are you thinking about that?
I really think that it brings it full circle because it requires us to really think about whole person care. And I know we've talked about that on other episodes, but, a lot of times people can't even, and going back to basics, when we think about, Maslow or just even other theorists, that there are other things that we need to solve for first before we even talk about taking care of the physiological needs. And so what are the psychological needs of that patient? What are the social needs of that patient? A lot of times you have to solve for those first. Just thinking, if you have someone that is worried about getting food or doesn't have transportation to get to the pharmacy, it's highly unlikely that you're going to get them to take their statin, right, with any regularity. And so, looking at ACO REACH, and just programs overall, you have to solve for those challenges first if you want people to take up, right, those different behaviors or those behaviors that are sometimes more challenging to improve health outcomes. And so when it comes to REACH, there's definitely an importance around tracking social determinants of health, because like I said, you're not going to be successful unless you address those things first. And the other thing, though, that I see, I know you talked about winners and losers. One of the things that I am seeing in the community is that a lot of people signed on for this program, knew it to be a great thing, was really going to help move healthcare forward. But the challenge has been that, these patients are still utilizing healthcare in a way that is similar, right, to how they've done it before. It's not really amenable to the ACO REACH model. And so if you're not taking care of food scarcity, if you're not taking care of housing, those behaviors of showing up in the ER maybe when it's not appropriate, because that isn't the type of care that they need, your cost of care is just exorbitant. And so, REACH is really based on that. It's managing that patient and all the pieces of care.
Absolutely. And I see this trend in CMS. I was just looking over the proposed physician fee schedule for 2024, and there are provisions for certain G codes now for performing SDOH assessments, and the providers are going to get paid on those. And I think even clinical staff can make those assessments. So this is a healthy change, and I think this is a trend we'll continue to see from CMS to emphasize the SDOH and social diagnoses, not just limiting to what we have been traditionally thinking of clinical data. So I think in the first year of ACO REACH it's just the demographic data, but hopefully in the next few years we'll see more emphasis on SDOH. What are the other differences from MSSP which makes this program more attractive or less attractive? How should an entity go about it?
Well, I think one of the other things is developing these health equity plans. And so, just picking up and segueing off of talking about social determinants of health, it's really around how are we developing programs that address particular conditions. And so are there either certain demographics or certain disease sets, right, that need additional focus or additional care? And so looking at, say, cardiovascular disease, developing programs around diabetes management. Even I think that there's an opportunity around our women's health. A lot of times we're so focused on Medicare Advantage, but we really have to think about the entire lifespan. And so, what are you doing around making sure that patients are getting good pre and postpartum care? And so lots of opportunities to really focus on populations and the needs of your community. And I really think that, that's the larger trend, is looking at, what do patients need, meeting them where they're at, helping them in a way that makes sense, connecting them to their community, right? Those types of connections and relationships. In this world with technology, a lot of times we can maybe do things faster, but in doing so and building efficiencies, we still have to remember that, nothing can replace those relationships. And so how can we continue to further those types of connections?
Absolutely. I think that's fundamental to any VBC program, to manage these conditions and look at the patient holistically. But just going back to the mechanics of the program, I thought one thing which is interesting is, as everybody's aware, there's a global risk option and a professional risk option in ACO REACH. But what really got me interested is that there is no MSR for the professional risk option. So minimum saving rate is something which is limiting to an organization's ability to take profit on the first dollar, because there is usually a certain percentage that they have to overcome. But here they can have this money coming back to them on the first dollar. So I thought this was an interesting point. What do you think? People are aware of that, or we need to talk a little bit more about these financial arrangements?
We definitely do. When I looked at who the entrants were going to be for 2023, the majority signed up for global risk, and it all sounded good, right? But if you don't have the infrastructure, if you don't have the tools to do that work, it can be really challenging, because it includes, right, you're on the hook for everything. And so it's not only taking care of the patient in your office, but then any of the expenses that come with that as well. And then in addition to that, so when you think about professional risk, it takes out, it's 50-50. It takes out that whole person care as far as like hospitals and things like that. So, the total cost of care arrangement is different. It's a different configuration. And so while a lot of groups took on global risk, and I love the energy around that, I think that, maybe some, until they had that infrastructure put into place, might have thought about their communities and what tools they had in place, what infrastructure, and perhaps professional risk would have been the better choice for them.
Absolutely. That's the one we would recommend if somebody's just starting out on
Absolutely.
this. I think very important to have the right tools to look at your entire population, to have a strong network of providers who are affiliated or employed by you. Some organizations are just much more mature and they are easier to navigate than others. That's been my experience. So if one feels that they have the right tools, the data is flowing correctly, and they have the right network of providers who are aligned in their objectives, I think it's very, very critical. They're financially and conceptually, strategically aligned within these groups, then I think it's easier for these organizations to step forward and take up this risk, whether it's MSSP or ACO REACH.
And I agree with that recommendation. I think that if you're new to REACH and you don't have the infrastructure in place and you're not managing cost well, I would recommend as well professional risk. And essentially, you can do a lot of the things that I think folks have been doing for a long time and they've gotten good at. However, you need to have that intelligence to be able to inform those visits. But making sure that you're seeing your patients, right? Counseling them on the importance of taking their prescriptions regularly, making sure that they're getting in, and of course, our quality measures are important. So making sure that they're getting in and getting their preventative screenings. And so all those things would be incredibly important. And I would make sure that I had those pieces in place first before I started to branch out and look at, how do I start making sure that the site of care, right, that we're deferring particular procedures to the ASC versus the hospital, making sure that our physicians within our network and where patients are going, that they have the ability to go somewhere that's more appropriate for what they need in those after hour urgent, emergencies, not emergencies, but after hour needs for care. And they're not showing up at the emergency room and getting more care than they really need or is appropriate, or exposing themselves, right, to other types of conditions or germs or what have you.
That makes a lot of sense, that a practice or an organization really need to look at their patterns. They need to look at what kind of the environment they're in, where are their patients going to. The in-network and out of network also plays a role, don't you think so?
Absolutely. So making sure that you have enough of the specialties that you need, that your network, right, is diverse but also well supported, and then looking at those contracts as well. So making sure to forge those relationships. The other thing that I would recommend too is take a look at your roster, because when they're calculating cost, it's really important to know that's who's on there. And so if you have a roster full of specialists, that obviously, right, is going to increase what your total spend looks like. And so making sure that you have, again, that rich network, but also having that balance as well.
Yeah, that's really important. I think that providers are aligned and they're looking at the right metrics also, and they can manage their own provider network as well, and have the right platform to look at the cost and care of that population. I think that these things are very, very important. These capabilities, for example, are the patients getting their PCP visits and AWEs rather than going into their specialist visits? So metrics like those you mentioned, ER visits, the readmission rates, the length of stay. So I think all these metrics we need to continue to monitor to really make a difference. And that's the same across all VBC programs, I think. Whether it's REACH or MSSP, just the financial benchmarking is different. I think the base years are different. The MA rate book usage in Pioneer ACO, NextGen, DCE, and now in this ACO REACH, that's different from SSP, which looks more on the fee-for-service data. So these are some similarities or differences that I see. Any others you want to point out?
One that I can think of is the 3%, right? So with ACO REACH, a lot of folks have entered into those contracts, and they're looking back at your patients and what their claims have been and what their risk scores have been. And so if you weren't doing great at documentation, and then you enter into ACO REACH, depending on what your base year looks like, you do have a governor. Now, the thing is if you have a bad year, it protects you too. But essentially, you can only increase by 3% up or 3% down on your risk score. And so if you have a patient come in, right, and they're past their base risk score is not accurate, right? Say that it's lower than really what should reflect the patient's acuity, do not think that when that patient comes to see you that, oh, I'm going to start now and do great documentation and then I'll catch up. It doesn't work that way. You can only improve by 3% year over year. And so it's really important as you're considering entering into these contracts. And again, that nod to global or professional and trying to make that decision. How good have you been? In the past, where are the opportunities, and really being thoughtful about the tools that you might use. Now, here's the thing too. I don't think we should make decisions just based on the finances, right? We want to make sure the whole point of the program is to have the monies that are needed to really take care of these patients and provide the care that's necessary. So I don't want to say to someone, oh, don't consider REACH because you were terrible at documentation and closing quality gaps and managing your patient population, that you have to do all this work before. Not necessarily. You can catch up in time. And of course, you want to make sure that you're managing the patients. But that's exactly it. To the point that we were making is the focus is on not being reactive in medicine, but being more proactive. How can I manage the patient at the outset so that they're getting good care in the primary care setting, getting all of their screenings, right? Taking their medications, so on and so forth, at the appropriate site of care. And we're really staving back, right? Changing that typical disease trajectory that one might expect in the healthcare system of old, but managing those conditions so that we can manage costs along the way, so that hopefully our diabetics, right, are practicing healthy eating, they're getting exercise, they're getting all their screenings, they're taking their medication. And so hopefully you can prevent them, right, from having a more exacerbated condition in the future. That's really what it's all about. And to your point too, value-based care on the whole. When I look at ACO REACH, I don't think the goals are that much different. I mean, sure, there's some nuances. The goals aren't really that much different, though, than Medicare Advantage. It's just really who's holding the contract.
Exactly, I agree with you. This is just a path for different organizations to take on as much risk as they are ready, rather than going all the way to Medicare Advantage, global risk for 100% capitation. So I think this is a great opportunity for folks to try this model. And as you said, in the end, it's the care of the patient which really, really matters. And if we can shift the graph towards earlier screenings and keeping them away from hospital when we don't have to send them, that is what it is all about.
Absolutely agree. And the other thing that I love about it, though, too, is that it puts physicians in control and gives them an opportunity to have a run at doing that type of work. And so really excited to see what some of the results will be.
Absolutely. So we are waiting for that. I think we saw some quarterly results on ACO REACH, on the organization they have joined. Nothing really jumps out, but we are waiting for the year-long results. And then hopefully we can learn lessons on what the journey has been and how much savings there are for CMS and for the ACOs. But we obviously wish our participants luck. Persivia does take care of ACO REACH clients, so we are heavily involved with them in every little part of that formula that we have to look at. We fine-tune and we went through with all that calculations, which are interesting, the way they're calculating the HIBA, the equity adjustment, and how this plays into the benchmark years, which are pre-COVID. So we're looking at all these different things. And I know that you are also involved with some of the ACO REACH programs. Any personal lessons learned before we conclude this?
I think you brought up all really good things. And like we've been saying, you need to know your patients. You need to know how best to manage them. And if you don't have the data aggregated in a way that tells a clear story, it's going to be difficult. And so I do work with a lot of organizations that have ACO REACH programs. One of the other nuances, is not being able to do a lot of the retro work. So that retrospective work that you would do in Medicare Advantage. So having that information, the data of which you speak at the point of care, so that physicians can use that to capture it at the visit, not retrospectively, but to make sure that they're able to get that during the visit and submit that. Make sure that the claim is accepted in its entirety is super important. So, to the extent that you can get that data, look at tools such as Persivia, I think will be really important as to whether or not a group is successful. I've seen a lot of groups without the data have just launched and now are finding, right, that there's a lot of Monday morning quarterbacking, if you will, of, coulda, woulda, shoulda. And I think that there's, there needs to be more thought put into it before entering into these types of arrangements.
Great. Thank you so much. With this, we conclude our first episode of ACO REACH. Thank you, Dr. Decker.
Thank you.